In the last sketch, we took a terrifying journey into our repressed childhood memories at Zany Zankers, where we discussed some of the more annoying pathologies of the upper and lower esophagus, including the big one, GERD. And while GERD may be annoying enough, its transformation to adenocarcinoma is, well, downright soul-chilling. And if you thought the nightmare of macabre malfunction mechanical mammals was over and that the healing could finally begin, well, unfortunately. In this sketch, we'll venture bravely through the bowels of an animatronic animal to discuss malignancies and motor dysfunction of the esophagus. First, we'll continue with the GERD theme and take a look at adenocarcinoma. Then we'll cover squamous cell carcinoma of the esophagus, which is associated with even more terrifying risk factors. Beetle nuts, beetle nuts, beetle nuts! And after that, we'll wade through the mire of some of the mechanical disorders of the esophagus, including Plummer-Vinson syndrome, achalasia, diffuse esophageal spasm, and crust syndrome. All of these disorders cause the same presenting symptom, dysphagia, or difficulty swallowing. So we've brought back that old stage acting trope, the vaudeville hook, right to the throat. As we prepare for the next act, you're going to get a behind-the-scenes look at dysphagia caused by tumors, webs, motor dysfunction, all kinds of stuff. The key here is to think about the other signs and symptoms that characterize the dysphagia. Is it progressive, first affecting solids and then liquids? Is it associated with pain? What does imaging show? Let's get the worst diagnosis out of the way. Esophageal cancer, which can be adenocarcinoma or squamous cell carcinoma. To the left of the curtain, we're going to illustrate adenocarcinoma, the most common esophageal malignancy in the U.S. It tends to occur in older people and is 7 times more common in men than women. The adeno part of adenocarcinoma means you'll see gland-like features on histology, of course. So we always try to include some kind of gross-looking glandular stuff. Kind of like the stuff and fluff popping out of the animatronic bear out on stage. I guess it's some kind of off-Broadway Goldilocks, or Five Nights at Freddy's, maybe? Wait. I recognize those haunting, lifelike eyes. That crusty, poorly maintained exterior. It's the Barrett's bear. Barrett's esophagus is the cause of pretty much every case of adenocarcinoma of the esophagus. Recall from our Zany Zenker sketch that Barrett's results from chronic GERD. The normal stratified squamous epithelium of the distal esophagus undergoes metaplasia. It's replaced instead by columnar epithelium, similar to the mucosa of the intestines. That's called intestinal metaplasia, represented, just like last time, by those metal intestines, popping out of his empty, lifeless shell. Pretty disturbing, actually. Though, as you know, at Sketchy, we're all about remembering stuff. And what's more memorable than something you wish you could unsee? As metaplasia continues, the cellular genome accumulates mutations, causing metaplasia to progress to dysplasia and, eventually, invasive adenocarcinoma. An interesting contributing factor to this phenomenon, especially in patients with pre-existing Barrett's esophagus, is smoking. Another good reason to talk to your patient about smoking cessation. Let's highlight the bottom of the curtain, because adenocarcinoma most commonly affects the distal third of the esophagus, including the GE junction, which makes sense when you think about where all that metaplasia and dysplasia occur in the setting of chronic GERD. Cancer can even develop more distally, in the gastric cardia. Remember, the overarching motif here is dysphagia, or difficulty swallowing. Esophageal cancer usually causes a progressive dysphagia, initially for solids and then for liquids. Think of it this way. When a mass sits in the esophagus, big solid chunks get caught first. But as the mass gets bigger, even liquids have a hard time. Way in the back, we've illustrated the early stages of disease, when solids get stuck, but liquids pass on through, as depicted by the theater patron's rotund mass of a body getting caught in the aisle, while he inadvertently lets his drink fall right on through. Remember, though, as disease progresses, even that drink won't make it through. As the dysphagia gets worse, patients just aren't able to eat like they used to, resulting in weight loss. Patients may also experience a retrosternal discomfort or burning sensation, as well as pain with swallowing, also called odynophagia, kind of like a hot bite of pizza sliding down that esophagus. Slow down there, buddy. Unfortunately, by the time these signs and symptoms become apparent, the cancer is usually pretty advanced. Because of its aggressive nature, late presentation, and early spread, the 5-year survival rate for patients with esophageal adenocarcinoma is only around 25%, even with aggressive chemoradiation and surgery. While adenocarcinoma is the most common cause of esophageal cancer in the United States, squamous cell carcinoma continues to be the most common esophageal malignancy worldwide, though incidence varies quite considerably between geographical regions. The highest rates of squamous cell carcinoma are found in an area dubbed the esophageal cancer belt, which includes northern Iran, Central Asia, and north-central China. It's not entirely clear why rates are higher in these countries, but a few factors might be at play, usually involving poor nutritional status plus some kind of esophageal irritant. To see what kind of irritants I'm talking about, let's head over to the craft services table. Take a look-see, Oh, here we go. Man, they brought out the good stuff. Is Matthew Perry on set or something? No. Is it Katie? Wait. Luke? Ugh, frickin' Luke. He's like my favorite Perry. No wonder they brought the spread of delicious preserved meats. Hold on there. No touchy. That's for Mr. Perry. Not to mention that a big risk factor for esophageal squamous cell carcinoma, in Asia especially, is the ingestion of foods containing N-nitroso compounds, which include certain pickled vegetables and preserved meats. What else is on the menu? We've got some hot tea. Really hot. Though, I'd avoid that too, because ingestion of really hot beverages and food can contribute to the development of esophageal squamous cell carcinoma as well, probably due to direct mucosal injury. In Iran, for instance, consumption of really hot tea has been shown to significantly increase the risk of cancer. So let's see. What else is... here's an exotic one. Betel nuts, also called the areca nut. This is a popular chewable nut throughout Asia that has certain vasoactive and psychoactive properties. And, wait for it, you know it's coming. Yep. Chewing betel nuts has been linked to the development of squamous cell carcinoma of the esophagus. In the US and Western Europe, cigarette smoking and alcohol consumption are the most common offenders. Also in the US, it's 4 to 5 times more common among blacks than whites, a disparity that can't be fully explained by differences in smoking and drinking habits. Unlike adenocarcinoma, SCC is most often found in the middle third of the esophagus. Aw, why aren't you the cutest little thing? With a little tutu right in the middle. Nice and snug. Like adenocarcinoma, patients with SCC of the esophagus present with progressive dysphagia. In other words, yet again, we're dealing with solids getting caught first, where liquids are impeded in more advanced stages of disease. And there can be chest pain as well, along with odynophagia, or painful swallowing. Watch it there. The sign clearly says that it's hot. Dysphagia eventually leads to weight loss as well, hence the thin physique. A little too thin. You look like a White Walker or something. All right, you remember those Barrett's bears? Herniating glandular stuff and fluff? Adenocarcinoma of the esophagus tends to form exophytic masses. Those penetrating eyes. Almost like he's trying to tell us something. No. Moving on. Sorry about that. Eerie. Anyways, squamous cell carcinomas appear a little differently, usually plaque-like thickenings with ulceration. And that's why we've made the tablecloth have the same pattern as the floor, to make it look like a raised flat area. A plaque, if you will. Histologically, esophageal SCC demonstrates flattened polyhedral or ovoid epithelial cells with eosinophilic cytoplasm, and those classic keratin pearls with intercellular bridging common to other forms of squamous cell carcinoma. Unfortunately, squamous cell esophageal carcinoma has a similar prognosis to that of adenocarcinoma, with a 5-year survival rate around 25%. All right, we're going to continue our theme of dysphagia with dysmotility disorders, pathologies that inhibit the normal mechanical function of the esophagus. First up, Plummer-Vinson syndrome. The most important thing you need to remember about Plummer-Vinson syndrome is its cause: chronic iron deficiency, as depicted by the plumber's iron tools falling to the floor. Plummer-Vinson is characterized by the very specific triad of dysphagia, iron deficiency anemia, and esophageal webs. The distinctive esophageal webs seen in Plummer-Vinson are thin protrusions of the esophageal mucosa, most commonly found in the upper third of the esophagus. So in the cross-section of the pipe, notice that we've only made the inner mucosal layer projecting inward. These esophageal webs cause dysphagia for solids only. Liquids are able to make it down the esophagus without issue. So again, pay attention to the guy in the back who forgot how doors work. Those liquids just squeeze on by. The third pillar of the Plummer-Vinson triad is iron deficiency anemia, hence the pale, anemic overalls. Once again, remember that this is just a manifestation of the presumed cause of Plummer-Vinson, chronic iron deficiency. Interestingly, patients with Plummer-Vinson syndrome are at an increased risk of esophageal squamous cell carcinoma, a result of chronic food entrapment within the esophageal mucosal webs, causing chronic inflammation and dysplasia in the esophagus. See how irritated that squamous tile looks? In fact, in this sketch, everything that we illustrate above that squamous tiled floor can increase your risk for squamous cell carcinoma of the esophagus. This even includes our next esophageal dysmotility disorder, achalasia. Achalasia is a neuromuscular disorder of the esophagus causing impaired relaxation of the LES and a functional esophageal obstruction. And when I say impaired relaxation of the lower esophageal sphincter, I want you to think of Michael Keaton over here, with that tight harness really squeezing down on that esophagus. And when I say functional obstruction, I mean an obstruction not caused by a mass or web. You see, with achalasia, the lower esophageal sphincter can't relax due to the loss of the myenteric, also called the Auerbach plexus. And now that I think about it, someone really should look into getting that safety plexus fixed. The myenteric plexus is normally responsible for producing nitric oxide and vasoactive intestinal peptide, or VIP, both of which help relax the smooth muscle in that lower sphincter. Because nitric oxide is a gaseous neurotransmitter, it's represented, as always, by nitric oxide exhaust. And VIP? Symbolized by that VIP backstage pass, of course. To highlight that both of these transmitters are decreased, the NO exhaust pipe is all bent and rusty, and that VIP pass is broken and falling to the floor. As a result of increased lower esophageal sphincter tone, the area just proximal to the sphincter dilates, and normal peristalsis of the esophagus is disrupted. Most of the time, the cause of achalasia is unknown. Actually, in other words, it's idiopathic. The old idiot sign taped to the back gag. Gets me every time. It's possible a virus causes an autoimmune response targeting the myenteric plexus. Or maybe there's some kind of genetic predisposition. We're not really sure. Achalasia can also be acquired, although this really only happens in Central and South America. That's because secondary achalasia is a complication of Chagas disease. You remember Chagas from Sketchy Micro, right? Che making out with his girlfriend over at Che's gas station? Well, we've brought back Che's gas to remind you that the amastigotes of Trypanosoma cruzi cause direct destruction of the myenteric plexus, leading to the same downstream effects of achalasia. Check out our Sketchy Micro video for everything on T. cruzi, including an in-depth analysis on the exploits of Che Guevara. Regardless of how it happens, achalasia has a very unique finding on imaging. On barium swallow, you'll see a classic bird's beak appearance, where that super tight lower esophageal sphincter sits. This shape is evoked by the beak of his mask, dilating a bit and then coming to a sharp point at the bottom. If you see this picture, you'll know right away that it's achalasia. A patient with achalasia will present with regurgitation of undigested food. I mean, that does look pretty painful. And dysphagia for both solids and liquids. Yep, this time liquids are affected too. Hence the backup of fluid at the funnel. Treatment for achalasia centers on opening up that lower sphincter. Procedures such as pneumatic dilations via EGD or esophagomyotomy can be effective, as can botulinum toxin injections into the musculature of the sphincter. If achalasia represents a lack of peristalsis through a dilated esophagus, diffuse esophageal spasm represents uncoordinated peristalsis. Food boluses normally cause the esophagus to contract in a smooth, coordinated downward manner, pushing that food down and into the stomach, like carefully lowering one of these sandbag weights. Nice and smooth. Nice and... Oh, God. Ugh. Oh, man. Got a rope burn. This is like the worst date ever. Well, as you can see, impaired inhibitory neurotransmission within the esophageal myenteric plexus can lead to diffuse, uncoordinated contractions, which is the case in diffuse esophageal spasm. Again, I want to contrast this with the diffusely relaxed esophagus seen in achalasia. That's right. It was only that lower sphincter that was contracted. Well, this time, the whole thing is just contracting all over the place. Just like achalasia, patients with diffuse esophageal spasm will also demonstrate a very classic finding on imaging. This time, characteristic corkscrew contractions will be seen throughout the esophagus on barium swallow. Esophageal manometry can also be used to diagnose DES and will show disorganized, non-peristaltic contractions. While the mechanism may be different, the end result is similar to what we saw with achalasia. Diffuse esophageal spasm causes food regurgitation and GERD. You got something coming out of your, never mind. Just like with achalasia, patients also experience dysphagia for solids and liquids. Hence the liquid overflowing from his lifeless mouth. Probably should check a pulse or... Nah, he's good. Look for a history of intermittent retrosternal chest pain. You're just walking around when, bam, sandbag to the chest. Don't even see it coming. Interestingly, the chest pain of diffuse esophageal spasm feels similar to angina, and the pain can even be relieved with calcium channel blockers and nitroglycerin. What? So the question stem will most likely involve additional symptoms such as reflux, and they'll probably give you that corkscrew esophagus on imaging. You never know though, so keep that angina anvil on your differential. Okay, it's time to wrap up this dysphagia musical with our last pathology, Crest syndrome. Crest syndrome is a specific variant of systemic sclerosis, which is an autoimmune disease primarily targeting the vascular endothelium, leading to chronic ischemic connective tissue damage, excessive activation of fibroblasts, and progressive tissue fibrosis. To represent Crest, we have, well, a crest. An old stage prop, it seems, from last year's universally panned production of Man of La Mancha. It's better to just keep those memories buried. The acronym CREST stands for calcinosis, Raynaud's syndrome, esophageal dysmotility, sclerodactyly, and telangiectasias. The sclerodactyly is represented by the scaly dragon talon, and all of the aspects of the syndrome will be covered in much more detail in our rheumatology unit. For now, remember that E for esophageal dysmotility. Esophageal dysmotility in Crest syndrome occurs because of atrophy and fibrosis replacement of the muscularis in the lower esophagus. Without smooth muscle to push ingested food down towards the stomach, this leads to decreased tone within the esophagus and dysmotility leading to GERD that can progress to Barrett's esophagus, just refluxing right up to that Barrett's eyes, penetrating my empty shell of a... Oh, jeezy crazy. No. Time to sum up the sketch. GERD is annoying, to say the least, but if left untreated, can lead to much more serious consequences. Chronic or untreated GERD can lead to Barrett's esophagus and eventually adenocarcinoma. All that glandy stuff and fluff. Smoking doesn't help either. It makes sense that most cases are seen in the lower third of the esophagus at the GE junction, where all that bubbly is happening. The classic patient with esophageal adenocarcinoma will present with dysphagia, weight loss, and sometimes chest pain and will most likely have a significant history of GERD. Squamous cell carcinoma, on the other hand, tends to affect the mid-esophagus and is most highly associated with irritants such as smoking and alcohol. Those are the big two to remember for the test. Patients with SCC will also present with dysphagia and weight loss, but may have a history of Plummer-Vinson syndrome, achalasia, or other esophageal diseases causing chronic inflammation. Speaking of, Plummer-Vinson syndrome is thought to occur secondary to iron deficiency and presents with the classic triad of iron deficiency anemia, esophageal webs, and dysphagia. Achalasia is caused by destruction of the myenteric nervous plexus of the esophagus and leads to increased tone of the LES. This leads to obstruction, dysphagia, regurgitation of solid foods, and increased risk for SCC. In developing countries, It may also occur as a result of Chagas disease. A little overboard with that Chay's gas. Either way, the pathognomonic finding is a bird's beak appearance on esophagram. Diffuse esophageal spasm is caused by uncoordinated contraction of the esophagus, causes dysphagia and chest pain, and has a corkscrew appearance on esophagram. And finally, Crest syndrome, also known as limited scleroderma, is an autoimmune fibrosis of the distal esophagus that can lead to chronic reflux and development of Barrett's esophagus and adenocarcinoma. All right, we're making good progress here. Let's keep working our way down. Stomach, here we come.